All right. Well, good morning. Thanks again for the invitation to do this lecture and talk a bit about pediatrics. I always appreciate the chance, though. I feel a little bit odd again talking after Barb last week. I think this was intentional because of the conversation last week, but much like last year, I feel like putting me after excellent speakers just makes me nervous. But I appreciate the chance to talk about some pediatric decision making and how it's a little bit different than the adult world. I don't know why I can't. Oh, there we go. I'm not sure if I use disclosure slide or not. I don't have disclosures other than the other thing that makes me nervous is I know a lot of people on this call have more experience in this realm. And I know that our newest fellow from Trinity is actually an ethicist as well. So when I talk about some ethics things, please feel free to chime in and correct me. I appreciate good conversation about some of these topics. So I'd like to start with the patient. And same case I used in the past, I know, but I think it's an interesting one. This was a 16-year-old male with a long-standing history of a neurodegenerative disorder, including juvenile Parkinson's and at least two other disorders that were vaguely described, and the details were a bit cloudy, even to the neurology. But over several years had significant clinical decline, and now unable to ambulate, communicates with thumbs up, thumbs down, and is entirely dependent on G-tube feeds. And the family really struggled watching his decline over these years and feel they are really torturing him with ongoing interventions, including those feeds. And he's admitted with worsening agitation, combative behavior, especially when his feeds are connected. He makes motions trying to basically stop them from doing it. And they feel his quality of life is pretty awful. Over these years, he's also expressed in various ways via writing or other things that he wants to go see Grandpa in heaven. And they ask our team about stopping his feeds. I used to ask, like, okay, what do people respond? But again, I'm preaching a little bit to the choir in this lecture. So I'm not going to ask that because I think most people on the call might say, well, this seems like a reasonable thing. We're in palliative care and hospice. This is the kind of thing we talk about. In pediatrics, it is quite a different discussion, as we'll talk about this morning. But I'd like to put that as the foundation because while it may seem simple and straightforward to most of us in palliative care, I can promise you to my pediatric colleagues, they think that this notion is crazy of entertaining this idea, which we'll get to. So the objectives, I want to talk a bit, as I mentioned, about how this is different in pediatrics versus adults. Some of it might be obvious, but there are some nuances that make our work really interesting and challenging, and we never know exactly how some of these cases will go. And then talk about some of these specific challenges that we face around some very particular decisions and what families can or can't decide. And then a bit about advanced care planning in pediatrics on the heels of Barb's wonderful lecture last week. How is this different in peds and what does it look like? And some tips and tricks as far as how we do this work. So I often start this with a brief review of ethics. Everyone in the call knows this. I just put it up because when we talk about decision making, it bleeds over into the ethics world. And one of the challenges in pediatrics is who are we looking out for? When we talk about acting in the best interest of the patient, what about the parents? The idea of not doing harm to who? Harm to the child or harm to the parents if we take away decision-making rights. Similarly, autonomy is the autonomy of the parent to make a decision or the child to weigh in on that decision, depending on their age. And the same with truthfulness and honesty and informed consent. We'll come back at the end of the discussion and talk about informed consent and my issues with how that process goes and is it truly informed. So this won't be a big ethics review, but I think it's a good place to start because in pediatrics, it's confusing about who exactly are we talking about. That's our big balancing act at the heart of what we do in peds is we're focused on the child as our patient. We're supposed to look out for their best interest and their well-being, but we're balancing not only our responsibility as providers, but what about parental autonomy? What about the child's vulnerability in this situation? What does our society have as far as interests and responsibilities for that child and family? The child's developing autonomy. If they're taken away from that family, what does that do to their development and whatnot? So this is the kind of the balancing act that we try to do, and it gets very confusing as to which one of these will dominate in any given situation. So as we heard last week, very beautifully, adults can make their own decisions. They are presumed to be competent and have capacity. And Barb did a wonderful job of explaining those and when sometimes those change, but adults can speak for themselves. As I've often heard, adults are allowed to make what we might deem poor decisions, but if they're competent and capable, have capacity, then they can make that decision, even if we disagree. And if surrogates are involved, hopefully with a wonderfully signed and filled out MDPOA, as we learned, they are to use substituted judgment. What would that patient want when they can't speak for themselves? The challenge in pediatrics in kids is it is almost the complete opposite. They are presumed not to be competent by the law. So that legal competency, they're not. We can talk about, and we'll talk about a bit of how do you handle that in older teenagers, but the fact is it's 18, which we'll also talk about. But they're presumed not to be able to make decisions. And we presume parents are going to speak for their children and act in their best interest. So whether that surrogate is a parent or a legal guardian or the court system, that it is a best interest argument instead of a substituted judgment. Nobody's really asking what does the 6-month-old want. They're asking parents, what do you want for your child? And truly that question goes up all the way until one is 18, which we'll come back and talk about. But it is a different question that we ask or supposed to ask in pediatrics about the best interest, which, I obviously gets very confusing. Like I just mentioned about best interest of in whose opinion, which is at the heart of some of these challenges. When it comes to refusal of treatment, which is where we'll kind of start the conversation as far as decision-making goes, adults obviously can do this, so I won't belabor that. We all know that adults can reject life-saving treatments, even if we disagree with it, and the threshold for state intervention is high. Not that it doesn't happen, but it's a higher threshold overall than in the peds world. Parents have less discretion in refusing life-saving treatment. They can't just refuse everything just because they want to. And the state intervention based on neglect is a lower threshold. Which we deal with quite often on the pediatric side, and trying to figure out when do we pull that trigger and when is it neglect versus other things. So that's the world we're living in. But in the real world, then how do you actually figure this out between the patient, parents, and provider? Who actually gets to decide how does this work in the real world? Can parents actually refuse treatments? Can a child refuse a treatment? And we'll talk about age and how does that play into it. Does the prognosis matter? Obviously, the answer is yes, somewhat, maybe, as we'll talk about. And does the child's age matter? Obviously, we view this differently, perhaps with a 16 or 17-year-old than we would with a 1-year-old. And we'll talk through some of that. I try to make this a little more academic. So in updating it, I found this from several years back that actually talks about shared decision making and a beautifully simple algorithm to get through shared decision making. Clearly, it's not that simple. What is interesting is it talks about, is there more than one medically reasonable option? If there's not, well, then it's not really shared decision making, and we kind of go down that path, which is more of the, okay, you need treatment for your asthma. If you don't do treatment for your asthma, that's going to be a problem from a medical neglect standpoint. Okay. Many of the situations that we find ourselves involved with, I would argue there's not really one option. In fact, there may not be any options that are actually that good, which is my challenge with this kind of algorithm and decision making, is that step 2 about the favorable medical benefit burden ratio. I find that to be a really challenging statement for many of the interventions we're talking about in our patient population. That tracheostomy, that ventilator, that G-tube may be beneficial, but it may not be. And it really depends on kind of where the family's at in deciding these things, which I think for most of our work tends to push us down to that right side where it's more parent-guided shared decision-making. We've all been in those situations, and I think it happens a lot in pediatrics, where basically we feel like we dump it all on a family and say, well, here's all the options. What do you want to do? You can stop the ventilator if you want. I really get annoyed when I see ICU people point to a family and say that, because it puts it firmly on their shoulders. I don't think that's really shared decision-making. I think that's, here's all the options. What do you want to do? That's not really fair either. So while I like the fact that there's data and algorithms out there to help us through this, I don't really use them, quite honestly, because it kind of comes down to that conversation, which we do on the palliative care side all the time. But there's a reference of more details of that model if anybody would like. Now, before I go further, I do want to mention that there are limits to parental autonomy, right? As I mentioned, if families are choosing not to treat kind of simple medical conditions, we're not going to allow that. And the more extreme cases, obviously physical abuse and neglect, we don't stand for that. So I don't want people to think that, I'm suggesting parents should always be able to decide anything for their child. So these are actually cases just from West Michigan over the past several years, where parents have been found guilty of murder in abuse and neglect of their children. I don't remember the details of these, but they revolved around nutrition. They basically didn't feed. I think it was the baby in particular just was not being fed And it was a willful act on the parents' part found by the court. So I don't want people to think I'm endorsing these things, because there are limits. But then there's other controversial practices that get more confusing. So several years back in Detroit was a case that was in the news about female circumcision as a cultural practice that was being done by a set of providers in the Detroit area that were charged with a crime. And then flash forward a couple of years, it was actually dropped by the prosecutor's office, and there were no charges. So there are clear cases of abuse and neglect, and there's also practices that we could probably debate for a long time about, is that allowed or not from a cultural perspective and whatnot. So it's not as straightforward, obviously, as most of these things aren't. So I often start with refusal of treatment again about age or prognosis. As an oncologist, I've always assumed that if a 5-year-old child walks into comes in the hospital with acute leukemia, with a survival rate, if they have the right genetic factors and things, of upwards of 95%, even higher probably these days, I have to believe that there's not a judge anywhere who would say the family can forego that treatment. I don't know that for a fact. I've always just assumed it. What's interesting, though, is when you start to change the age and then maybe a lower prognosis, what happens to the ability for a family or a parent or a child to say, I'm not going to do this. The first case in green, we are getting close to holiday season, so I made it a little bit festive. It's really just the green cases are ones where the courts have said, yes, you're allowed to forego these things. The red ones are where they say no. The first case, the 10-year-old, is actually a patient from this community. This happened, I believe, around 2008, 9, 10, right before I sort of arrived to town. A 10-year-old male with rhabdomyosarcoma from the Upper Peninsula was treated with chemotherapy for 3 months, was found to be in remission after that, which was great news. And the family said, we're not going to do any more. There's no evidence of disease. We're done. The team here, the oncology team from Peds, said, actually, that's a problem, because we know from data, if we stop now, it will come back like 100% of the time. They went to court in the Upper Peninsula. It was a local court where they lived, and that judge ruled with the family and said they did not have to continue chemotherapy. So he did not get more chemotherapy. It's not sort of I told you so, but his disease did relapse. He went over to Wisconsin and got treated there. And unfortunately, last I heard, I think a year or two ago, he actually died after multiple relapses of this disease. Again, not saying that as I told you so, but these are local. These happen here as well. When you look at the literature, the case law and cases of this are all over the place. There's a well-known one about Abraham Chirix in Virginia, a 16-year-old with low-stage Hodgkin's, very treatable, who refused chemotherapy after the first round, and the judge sided with him and his parents. Importantly, his parents were in favor of stopping chemo and not doing more, and the judge said that's okay. In fact, it led to the passing of Abraham's Law in Virginia that allows teenagers and parents to make these decisions sort of against medical advice if they feel it is appropriate. So there's an evidence of, okay, well, we allowed a family and a child to make that decision. Daniel Hauser is a case in Minnesota. Except I messed up. He actually should be red. Apologize. That would make this a little bit more straightforward. He was a 13-year-old with low-stage Hodgkin's, same disease. Mom did not want him to get chemotherapy. She actually took him out of the state. A warrant was put out for her arrest, and they found the family and brought them back to Minnesota, and he was actually, they had him undergo chemotherapy. So I apologize. That one should be red to make it 3 and 3. Dennis Lindbergh is a well-known case from several years back in Washington, a 14-year-old with high-risk ALL, not as great of a diagnosis of a 5-year-old, as I mentioned, but still 80% or more survival rate. During induction in the first few weeks of treatment, he needed a blood transfusion. He was his legal guardian was his aunt, who was a Jehovah's Witness. He was a self-proclaimed Jehovah's Witness as well, and said that he did not want a blood transfusion because of his beliefs. Now, we're all probably well aware of Prince versus Massachusetts, the famous sort of quote that parents may make martyrs of themselves, but not their children. In this case, his biologic parents, who were not involved, did not have medical decision-making rights, but they were aware of this. They fought it in court. And a judge sat him down and deemed that he was mature enough to make this decision. It was not undue influence of his aunt, and they allowed him to forgo a blood transfusion, and he died in induction treatment. So for a disease that many would argue has a very good cure rate overall. What's interesting is the ethicist involved in this case just came and did grand rounds at DeVos last year. And we had some sessions with him in conversation. And he actually shared that he was involved in those discussions in that case after the fact, after Dennis died. He had conversations with, I think it was one of his school teachers, who shared that she felt that he was one of the most immature children that she had taught, but he did a fantastic job of covering it up, of putting a mask on and making people think he was more mature and whatnot. So hearing that in hindsight made people cringe a bit of what was that the right decision or not. But again, it goes to the legal system. The other two on the bottom, 9-year-old with severe autism, developmental delays, and acute leukemia in Massachusetts. Mom did not give him treatment during his last 2 years of treatment, which is the maintenance phase and oral chemotherapy. She was withholding it. And she got in big trouble for that. She was worried about side effects, did not tell anybody about those worries, and just didn't give him the treatment. He relapsed. They found out he wasn't getting meds. And she also got charged with, I don't know the level of charge, but criminal activity in that case, got in trouble for it. So if you look overall, it seems like, well, maybe younger patients, obviously we feel more protective of those patients and we shouldn't allow them to make decisions, though I guess those green cases don't necessarily, the 10-year-old, they certainly let forgo treatment. But in general, one would think that, okay, older, because I always wondered, how can you force a 16 or 17-year-old to get chemotherapy? Well, Cassandra Callender's case in Connecticut in 15 would suggest that answer. She also had Hodgkin's lymphoma. She told the team and her family that she did not want poison in her body and did not want chemotherapy. It went before a judge because the treating team did not agree. Her mother did. Her mother sided with her. But the judge sided with the hospital and said, you have to get chemotherapy. They put her in the hospital with an armed guard at the door and forced her to get chemotherapy, which I still don't understand how exactly that works, but that's what happened. Now, what's interesting in her case, her disease unfortunately relapsed a year or two later. Now she's over 18. She was allowed to make the decision herself. She opted not for traditional chemotherapy and for more holistic approach. And unfortunately, I believe it was a couple of years ago, she died from recurrent disease, for a disease that, again, is probably treatable. I don't know the details of her early treatment, but it is interesting that when she was 17, we forced her and basically kept her under lock and key to do chemo. You turn 18 and suddenly you get to decide, which is, I think, really interesting in that age of consent conversation. I could probably talk for a whole hour about just that and have lots of debate about the age of consent and should it really be 18? Can teenagers be expected to make rational decisions? I have 2 of them now, and my gut reaction is I'm not so sure. Well, actually, I know that maybe they shouldn't be. So I guess the age had to be declared somewhere, but 18 is certainly interesting. There is good data out there about the prefrontal cortex not fully maturing until maybe age 25, maybe a little bit older in males, 26, 27. I think this particular study that I quoted there did an interesting thing where they put teenagers in a MRI and had them drive on a driving simulator. When they were by themselves in the MRI room, they were very cautious while they were doing this driving simulator. When one of their peers was in the room, not even talking to them, not egging them on, not saying go faster, just sitting in the room, and the teenager knew that, their driving behavior became more risky compared to they did the same thing with adults and put people in the room and it didn't change. So it's sort of, well, terrifying. Again, I have a 16-year-old that just started to drive, so a little terrifying to think that it's not even a, hey, go faster, let's speed. It's, oh, you're sitting next to me, I'm going to be more dangerous. So lots of other data out there I know, and people who are far smarter than I am regarding the psychology of all that. But it is interesting of how this works with a 17-year-old versus an 18-year-old. So what do you do if that patient turns 18? Suddenly they get to decide. We may still think it's a bad decision. Do we take their capacity away? Do we take their competency away? There are lots of questions. And I think the answer there might be, if we really want to fight that involving ethics and legal and risk, that's a whole different conversation. But I just wanted to stop for a moment about that age of consent, because I realize it may not make a lot of sense, but we are stuck with this 18. So when we're talking about sort of these decisions in pediatrics, we truly are talking about children who are under 18. So shifting gears. Oh, yeah.
Yeah, I just, I was thinking about this. It was many years ago, and it came to us at Ethics over at Spectrum, and it was a 20-year-old, maybe 21-year-old, who was making irrational decisions. And I, I'm thinking, yes, adults get to make poor decisions for themselves, but this individual clearly had a less than 20-year-old level of maturity. Was diagnosed with it was leukemia or Hodgkin's, one of those very much treatable, and the family very much wanted this individual to get treatment, and said no. And it wasn't like there was some sort of overwhelming religious thing, or I don't want poisons in my body. No, I just don't want to do it. I don't have to, and I don't want to. And the parents actually took the legal step of having her declared incompetent, and she was admitted. I want to say Pine Rest, and treated against her will. And I often struggle with that, but on the other hand, you have kids that are teenagers now. I've been through 8 of them, and I can tell you that their decision-making capacity doesn't always look at the big picture, and I can say it's wrong. It's just wrong. And so I think it's something that we're never going to necessarily completely feel comfortable with, and where there's always going to be these challenges that we have to address and struggle with.
Yeah, and I appreciate that. And that's why I think in those cases, if someone is over 18, really the only way out of that would be the legal route to challenge the competency, really, and their ability to make that decision and take it out of their hands. I haven't dealt with that a whole lot, but that's really where the issue is. I think where it becomes a bigger challenge, and as you just pointed out, in that case that you mentioned, the family wanted treatment, and all those I just mentioned in the previous slide, the family sided with the child, basically. So that's where it becomes hard. Again, the one case in Connecticut, despite mom agreeing with the 17-year-old, they still went against both their sort of wishes. But I think the tendency overall is if a family is on board, there's probably less likelihood that, the system or the hospital is going to be successful, I would imagine, at challenging that even legally if the entire family is on board with what we deem as a bad decision. So it certainly is complicated. And as I said, we could probably talk about that for the whole hour. So, but shifting gears a little bit, what about other outside of oncology? Because that was sort of my former life, at least in many ways. What about other life-sustaining treatments? Can a family refuse to continue other things? This case illustrates, I could sort of update it to several others in the last year, but this was a 6-month-old born at 26 weeks with a very complicated medical history, chronic lung disease, pulmonary hypertension, on very high amounts of respiratory support, mechanical ventilation, pulmonary hypertension treatment, couldn't really wean off any of them, and now was 6 months old. And mom asked the NICU staff in passing one day, what if I want to stop? I don't think they actually asked, tell me more about that, which would be a great and really simple question. We did when we met mom, and she told us she feels he's just an experiment and he has a poor quality of life. And if we're just going to sit here for another 6 months in the same way, and he's not going to survive, or he's going to have all this stuff, I don't want to do it anymore. Which again, I realize I'm talking to a palliative care audience and people may resonate with that. But the NICU did not. The NICU actually told the mom 2 things, which are fascinating to me. One is, you should have told us that 6 months ago. You said start, so now we're going. And I'll have to talk to the rest of the NICU. And our NICU is interesting. And I love our NICU colleagues, and it's changed since I've been here for 8 years. But there's still a little bit of groupthink of, well, let me make sure everyone's on board with this, as if they get to vote kids on or off the island, I sometimes say. It's not fair to a family. So I could make the same case about one in the past year, similarly born at 23 weeks, severely premature, all the known potential complications, but the family wanted everything done. Flash forward 8-9 months, the child is severely ill, stuck on a ventilator, and all other complications. And the family said, we can't do this anymore. This did not go the way we were hoping for, obviously. And neonatologists had a struggle. One was like, okay, this makes sense. All the potential problems that we talked about, he's now lived into. It's okay to make a different decision. Other neonatologists literally said to us when we talked to them, "Why, this doesn't make any sense." The family, why stop now? The family said, yes, we've been doing this for 6, 8, 9 months. Why would they want to stop now? So again, not surprisingly, much of our work is with those teams to help them understand that maybe it's okay that a family can indeed say something different months into treatment. The idea of well, you started something, so you shouldn't stop it, is just wrong, right? I know there's not many absolutes in ethics, but at least for my learning and understanding, that is ethically the same. If an intervention is okay not to start it, it is okay to stop it later on, not without a lot of emotions and things I understand. But I think we do have this tendency, especially in peds, to say, well, we started it, so of course we have to keep going. And that I think is quite, well, wrong and mean to families who maybe want to try things. And if they don't turn out the way they want, it's okay to change course. So when these conversations come up, we get a lot of conversations around tracheostomies and ventilators. Sometimes we tie those two together too strongly, in my opinion. We may paint the picture of, well, if you do a trach, it's going to mean a trach event forever, which is also not true, right? This is not a one-way street. We can make different decisions along the way. If you decide about a trach now, you don't have to do a ventilator later. It's okay. So it goes back, not shockingly, to what is the overall goal? Is it a family who length of life at all costs is the goal? Okay, well, that takes us down one path. Or is it a quality of life question? And of course, the challenge is whose opinion of quality of life. And that is a big challenge in pediatrics, is many providers will say, well, kids can do really well. It's just a trach. Families don't like it at first, but they learn to really love it. That was a direct quote from an ICU doc once about a family who did not want to put a tracheostomy in their child with a severe HIE at 17 years of life. After 17 years of living in this, he developed all the chronic complications, and literally the family said the light in his eye is gone. We're not going to prolong his life artificially just so he can suffer more. A beautiful, heartbreaking statement and decision to make. The ICU doc, when I walked out of the room, that's what he told me. Well, it's just a trach. I don't know why they don't like it. It'll be helpful. Great for you. I know what you would choose, but this family can still make this other decision. So sometimes we put our own opinions about quality of life, especially I think in pediatrics, because we're afraid of the other result. The other question I like to ask sometimes, and I think we could talk about this for quite a long time as well, and I get myself into trouble. Sometimes when this issue of trach and vents come up, that's a lot for a family to go through, a lot of care. When a child's in the hospital, tracheostomies make their care easier. It's great, right? Ventilators, no big deal. We do it all the time. This is life-changing for a family, and not necessarily in a super simple, helpful way, right? You get home nursing, I use quotes. So you qualify for 12, maybe even 16 hours of home nursing, but filling it is a whole nother problem. And if you happen to live anywhere not near a city, good luck filling those hours at all. So I often ask the question of, does the family understand what that care looks like? And do you think they can take care of the child? I've been told on more than one occasion very quickly by the other treatment teams, oh, no, not at all. I don't think they can do this. So I always like to ask, well, should that not be part of the conversation if we're going to allow them to choose an intervention that's very aggressive and keep their child alive? It may not actually be curative, right? It's not actually fixing the brain anomaly and marching down a path where the child may not be able to be cared for by them. Should that not be part of the informed consent process? And it gets a little bit tricky because, I don't want to seem judgy of families and whatnot. I don't bring it up as a judging thing. I just think it's unfair to paint a picture of, hey, here's some great options, and then actually know in the back of my mind, but it may very well land in a spot where we're talking about foster care because you just can't do this at home, not because you're a bad parent, but because of the life situation and whatnot. So going back then to our original case of this 16-year-old with this long-standing neurodegenerative condition, the question, not now if we shift from ventilators to artificial hydration nutrition. Again, I realize the audience is probably thinking, oh yeah, we talk about artificial feeds and how they help or not all the time. This is one that I get told lots of comments about by my colleagues about, well, you can't just starve the patient. And I sometimes in my, as I've done this more and I get more bold, I'll ask them, well, if we take the ventilator out, are we suffocating them? Because again, the language we use is wrong, right? We're not starving somebody. We're allowing the natural disease process and the fact that their disease is leading them to not be able to take food and hydration the normal way. That's what is the heart of this, not us stopping something. So I've always appreciated these audiences and these conversations and the case discussions. This case was actually, I think we talked about it at one point as a fellow's interesting case. And I always appreciate Dr. Mulder's weighing in from his wise perspective of course, this is a terminal illness, because that was one of the challenges. Neurology actually said, we're not sure he even has a terminal illness. And I remember thinking, what? Because he can't walk, he can't talk, he can't eat, he can't move. clinically, he clearly has a terminal condition. Just because we can't name it doesn't necessarily name the exact thing, doesn't mean it's not terminal. And I think at that point, John, you were very clear about that, which then made me feel like, okay, good, I'm not crazy, because I appreciate feeling like I'm not on an island in these conversations. So the fact is, there is actually there are guidelines from the AAP around this exact issue, which every resident and fellow that rotates with us, we go over these because I know for a fact nobody else is talking about them. There's nowhere else in the children's hospital where people are talking about these guidelines. There was a clinical report from 2009 about foregoing medically provided nutrition and hydration in children. It outlines several different areas where this is absolutely legit to consider. It does not go as far as to say we should recommend it. And I don't do that either with families. I'm not saying, boy, you should really stop this. But if a family is worried about their child suffering, and I've asked that question before of, do you feel a child suffering? And families will say, oh yeah, every time I hang this feed, I know they're going to be bloated, they're going to be uncomfortable, but what am I going to do? We can't just stop them. And I gently will say, well, what if we did? What would that look like? What if the thing we're doing to keep them alive is actually causing more suffering? That's not fair. And there's other paths to take. I like the fact that these guidelines are out there because I've literally put this in charts before, in the NICU, for example, when this was brought up in some different situations. I'll share this with my colleagues to say, look, this is a legit thing. I'm not saying we recommend it for every family, but if that's the path that we're veering towards, it is okay to consider it. Not surprisingly, the NHPCO actually is a little bolder about their statement. Many of you are probably more familiar with this position statement on artificial nutrition and hydration than I am, but there is one paragraph about pediatrics where it comments on if the artificial nutrition is not treating, or I forget the exact language, but basically addressing the root cause of the problem, it should be stopped. If it's not helping the problem, well, that's a bit bold in my mind, because obviously for the kids that I'm talking about with severe brain anomalies, progressive metabolic disease, neurodegenerative disease, you're not actually, the artificial feeds aren't fixing anything. But they may still have a role. So I appreciate the bold language, but it is a little bit different than the pediatric guidelines. So shifting gears again to the opposite side, I feel like I'm flying through this, and certainly I want to leave some time for conversation near the end. But what about the opposite? Because the other situation we find ourselves in very often is when families are requesting treatments that we may feel are not beneficial. So do we have the right to say we are not going to provide treatment? Now, again, at the surface level, I feel, yes, we do. Logistically, how do you actually do that, right? None of us are obligated to provide treatment we feel is not, ethically appropriate. But how do you actually do that, right? How do you find someone else to do it, and yada, yada. But the logistics become difficult. So I use this child as an example. Again, this was several years ago. I could give you several right now at the moment in the hospital with the same sort of situation. Newborn with severe brain anomalies, intubated at birth, was felt to have anomalies not compatible with life. That was the first NICU note. This family, when this was discovered prenatally, dropped off the map. They did not see NICU prenatally. They did not see palliative care, as they were referred to both of us. And they just showed up when mom was in labor. And it was felt and literally written, these are not compatible with life, and they recommend removal of technology. The family flat out refused to limit anything. This child had a tracheostomy placed, had a VP shunt placed, was on full vent support, G-tube placed with artificial feeds, never opened his eyes, never moved. And there are several situations going on right now that are very similar. And the question that comes up oftentimes is, well, isn't this futile? Is this not futile care? And the challenge is, I often refer to futility as the other F word, because nobody likes to bring it up, right? We don't have a futility policy at our hospital in pediatrics. I think they're working on one in the adult side, and my adult colleagues can tell me if that's true at Corewell. The state of Michigan, last I knew, does not have a futility policy either. The most well-known state policy is in Texas, where if two providers agree that is futile treatment, they can fill out the paperwork, and then I think there's like a 72-hour or something period where the family can seek care elsewhere. But in Michigan, we don't have that. Last I looked, Michigan law says that their only comment on it from a legal standpoint is if a hospital has a futility policy, it has to be in writing. And if you're going to invoke it, you have to tell the family, which seems like a great use of the law to tell us common sense stuff of maybe you should have it in writing and mention it to the family if you're going to invoke it. So I don't find the law very helpful. But the fact is, we try not to get in the futility conversations because it's really tricky. Because if removing an intervention will lead to the death of a child, many people would argue right off the bat, well, it's not futile. It's keeping this child alive, keeping this person alive. So at its heart, it's not futile. So I think it's a tricky conversation. And as I always say, these are the ones that land us in the news and on Facebook and whatever more updated social networks there are that I'm not aware of, that sort of drags our names through the mud of, no, you don't want to help my child. You're letting my child die. So the hospital doesn't have a huge appetite, in my experience, to really go down that futility pathway. Now, what I find interesting is many of you may be aware are familiar with the Charlie Gard case. This is Charlie with his parents in England. Forget which hospital in London. He was a well-known case, I believe, around 2015. Of a baby who was diagnosed in the first few months of life with a neurodegenerative disorder, super rare, only a few in the world type disorder. He was eventually, by 6 months of life, stuck in the hospital on full vent support. Repeat MRI shows his brain was getting worse month to month. And the hospital said, we're stopping. This is futile treatment. This is England, mind you, right? National Health Service has a much different approach. They said, this is no longer appropriate medical care. He will not survive. We're going to stop. The family fought it and went through all the high courts of England and Europe. It's a whole different system of how families can fight this. And everywhere along the way, those courts agreed with the hospital. The family, in the meantime, started a GoFundMe and raised like $1 million to try to get him transferred to the United States. There was, I'm assuming, a well-intentioned researcher at Johns Hopkins who was doing research on mice with a neurodegenerative disorder that was not Charlie's, but something kind of similar. And he had an experimental med that seemed to help the mice. He responded to the family, bring them here, we can maybe try this. Lots of controversy and opinions. I will say that the overarching sort of opinion from this side of the pond was they should get to decide. They should get to do this if they want. There were tweets out from I believe he was a candidate at the time, Donald Trump, saying, save Charlie. The Pope was tweeting out, save Charlie. Palliative care people, there are very interesting editorials from palliative care, Pete's palliative care folks in the US saying this should absolutely be the family's right to try. And all along, England kept saying, no, they actually would not allow him to be transferred out of the hospital, even though it wouldn't have actually cost them. The family had money to do it themselves, but they basically refused. And eventually his ventilator was removed and he died in the hospital in London. Now, I always cite this case, and there's multiple other ones sort of since then, but the work that we do with families who are demanding these kind of treatments feels way different in this country, where we lean towards autonomy at all costs sometimes. And maybe you can tell by my voice that I'm expressing my biases, and I'll admit it, that I think our work would actually be easier, not less heartbreaking, not less awful, but easier in some ways if indeed there was this backdrop of, if this is not helpful, we are stopping, and we have this leverage to unfortunately say we are going to stop. That's not how our country works. And we have multiple examples right in our children's hospital of this type of case where one could easily argue the interventions we're doing are simply not helpful. They're not going to solve anything. But here we are, and we're stuck because of an, I would argue, a little bit of over-reliance on autonomy. You get to choose no matter what, even if it doesn't make any medical sense. Moving on a bit to truthfulness and honesty, I think that's the other challenge we have in pediatrics. So this is a young girl with, unfortunately, a severe intracranial hemorrhage. Very small amount of brainstem function remains. We'll get to brain death in a moment, and our challenges with that. But we have many, many cases where, okay, the patient is not brain dead, but very, really close. Very few reflexive movements, no purposeful movements, has not woken up, is fully ventilator dependent. The neurosurgeon and PICU are very honest with the family about this child is neurologically devastated and will not recover significantly from her injury. Neurology, in the same care conference or in conversations with the family, says this type of statement: there's a small chance that she might have some limited improvement. I'm not sure what that statement actually means, but I've heard similar things from my colleagues, and I'm not trying to discredit them too much, but these are confusing statements for families of maybe kind of there's a chance. And I think this is the point in the talk where I lose all my credibility. Well, in a moment I will, and I'll explain why. But again, doing an update recently, I kind of looked and tried to figure out this anecdotal sort of piece of, well, And why did that neurologist say that? Well, the other thing we hear sometimes is, well, this one time I had a child that the MRI looked just like this, and they walked in my office last week. I've heard neurosurgeons and neurology and all kinds of providers say those kind of things. And I think it's because we want to hang on to that hope of your child could be like that one. There were 100 others that did not recover at all, and I've seen all of them as well, and it did not go well in any way. But if I tell you about that one, maybe that'll help you feel better that there's hope. And I think that's unfair to a family as well. And we can talk about that one patient, but also talk about the others who didn't recover. This was an interesting study that looked at anecdotal information. It was actually around about research studies, clinical studies. And if a patient read a negative review of a patient experience on that study, even if the study was overwhelmingly positive as far as its outcomes for patients, that negative anecdote made patients less likely to sign on to the study because of what they read. Now, that's the opposite of what I'm talking about, because I think many times we lean on the one case that we remember that did well to give a family hope that this could be okay. And that's a fine thing to do, but we talk a lot about parallel conversations. We can talk about that path, but also talk about the what ifs. What if that's not the case? Because the likelihood is, unfortunately, it won't be the case. This is the point where I lose my credibility, because I think I've done this in years past as well. Right? When I quote Dumb and Dumber, I feel like people are like, okay, this guy's terrible. But really, it's the equivalent of you're saying there's a chance. So if you've seen the movie, you realize this is when he asked her if there's a chance that they could end up together. And he asks, is it like 1 in a million? And I think she says, no, it's more like 1 in a billion. And his response to that is that smile. And so you're saying there's a chance. And I feel like that's the disservice we do to families sometimes, and the balance we try to strike of, I'm not trying to take away all of your hope, but the more likely outcome is this. And we can continue down this path, but we have to also prepare for the alternative of what happens if the most likely outcome is indeed where this lands. So I think we have a big challenge in that in pediatrics, because we don't want to give up. And we'll talk about that in a minute as well. So I usually comment on futility and brain death as well, because I feel like in general, we should be good at this, and we should be able to at least, okay, if we declare brain death, then at least we're in a better spot. And we know there isn't really an option. I feel like asking a question after a child or a patient is declared brain dead, if you ask, well, now what do you want to do to the family? That seems to me like a confusing question that we shouldn't be asking. But unfortunately, we're not great at that either. These are two cases that both happened in Michigan, I think 3 or 4 years ago. One was in Royal Oak. I believe the 16-year-old was in Royal Oak at now Cornwall Health East. I think I got that right. Declared brain dead after an undisclosed brain injury. The family said, we don't believe you. We want everything done. Same thing happened in Ann Arbor to a 14-year-old after an asthma attack, unfortunately, declared brain dead. Family also refused. These were happening almost simultaneously. Both families took the hospital to court to try to stop removal of technology. And the judge in the one area said that, nope, the hospital has to respect the family's wishes, ordered surgery, trach and G-tube to go on a ventilator to somewhere before transferring to some sort of facility, which is a whole other conversation because there aren't really facilities for 16-year-olds, but said, no, the hospital can't do this against the family's wishes. The judge in Ann Arbor said the hospital can. And they went against the family's wishes, took the child off, and the child, well, had already died, in my opinion, but did not go through more surgery and was not at least kept alive in any way. What I find fascinating is those hospitals, when I looked, I think they're 70 miles apart. So when it comes to some of these conversations with families and how do we navigate this, we can't even necessarily get brain death right in some situations, in places where it's going to be dependent entirely on what that judge might feel or say, which really handcuffs any conversations we have with families, right? Because in the end, it may not be up to us. It may be up to a judge who's deciding some of this, which I clearly have strong opinions about. A word about informed consent. I've always wondered as an oncologist, again, when we plop down a 100-page consent in front of a family with their child with ALL, they're going to sign anything, right? They're going to sign anything that we want them to, as long as we help their child. So as we all know, informed consent is supposed to involve risks and benefits of proposed treatments, alternatives to treatments, and the right to refuse a proposed treatment. So the alternative to treatment may be not doing anything. And I think in PEDS, we often skip that step, because if we don't do something, the child will die. So we assume, well, that shouldn't even be talked about because death can't happen, right? So that's where I think we go wrong. And there's actually literature on this. It's a little old now. I'd love to repeat it now, 13 years later. But hypoplastic left heart syndrome is a very complicated problem. Surgery is better than it used to be, but it's still a pretty massive process of 3 different corrective surgeries, palliative surgeries, followed by eventually heart transplant when you're in your 20s. And the true options for a family where this is diagnosed are all those surgeries, go straight to heart transplant in some situations, compassionate care, comfort care right from birth, or even termination offered prenatally, depending on the age and everything else. What's interesting about this study, they looked at cardiac surgeons and cardiologists and what was actually discussed with the family. If this was known prenatally, only 35% discussed all of those 4 options. And most of the time, the option that was not discussed was comfort care. The idea of, okay, you can deliver, but then focus on comfort and not do the surgeries. If this was found postnatally, it dropped by less than half where all those options were discussed. And again, it was the comfort care part that was not discussed, even less likely to bring that up. Now the child's born alive, we have to do these surgeries. And that, unfortunately, is not really true, right? All of those options are still on the table for any given family. What's even more interesting is if you ask those providers what they would choose themselves, at least in, I think it was this study or a similar one, the majority of those providers would not pursue the aggressive surgeries, but yet they don't talk to the family about not doing the surgeries. So it's really interesting what they would choose versus what they even discuss with the family as options. It's a little scary to think that that's different. And it's a similar question that we get oftentimes in peds of what would you do if it's your child? And should this matter? I think it does personally. Now, I don't tell families what to do based on my own personal values and beliefs and goals. But if we have more conversations and I know where they're at, I'm not above sharing my opinion and saying I might worry about X, Y, or Z, right? Especially if we're talking about interventions that aren't actually curing the underlying problem. So that, again, we could talk for a long time about how do we address that question. I think the worst way to address it is, oh, it's not my child. Sorry. Can't really weigh in, because that to me is a slap in the face to the family, because I think they just want to know you're human and you're a smart provider, you're a smart medical person. Can you weigh in at all about how do we navigate this, which is obviously what our team tries to do. So many people have heard this before, that I often talk about a problem of being a child. If this adorable 8-year-old has a devastating traumatic brain injury because of a car accident, we very quickly, if things aren't turning around in the first week or two, talk about G-tube, trach, vent, and we say things like, well, time will tell. The pediatric brain is plastic and things can change, and right, put a lot of pressure on families of decide now or forever hold your peace, as opposed to we can try this for a bit of time and see if it's not a quality of life that you think is good for your child. At some point we can make a different decision. We don't really have those discussions as much as we should up front. When I say we, I mean the more royal we. Hopefully our team does, and we're trying to get more involved in exactly these kind of situations. I think the challenge of being a child is I think we're ageist in reverse, because if instead we make that patient this very nice 80-year-old with that same horrible brain injury, I know from hearing all my colleagues talk that occasionally it comes up where there's struggles with conversations around G-tube, trach, vent, all of that. But I do think we view it differently. I think, are less likely to paint a rosy picture of maybe someday what if, when it is a more elderly patient. So I'm not saying it's easy by any means. And ideally, as Barb taught us, we would have what this 80-year-old would want. But the problem with a 6-year-old or 8-year-old is we don't tend to ask them, right? And I've had amazing families who will view it that way, who will say, you know, I don't think this is the life they'd want to live. And they base their decision based on some of those kind of thoughts. I actually think that's a very beautiful way to approach it. We just don't often encourage families that way, or families will struggle and say, I just don't know what they'd want. And it's a 6-month-old. So I don't, no offense, the 6-month-old doesn't know what they want either. So it doesn't really help in some scenarios. So I always talk about the tangled web we weave. We have lots of kids we follow with severe neurologic disease, basically neurologic devastation, if you will, to different degrees. Families choose aggressive measures because they sometimes feel they need to. This is just what you do. Your child can't breathe on her own. They get a trach and eventually a vent. And they didn't necessarily know, or the door wasn't open to maybe making different decisions along the way. And I've seen this happen a whole bunch of times. The child declines, as we would expect. They keep coming back to the hospital, and hospital staff start to wonder, what is this family doing? Don't they get it? Don't they understand? Why do they keep putting their child through this? I argue that the challenge, the difficulty starts sometimes way in the beginning, when we don't necessarily have the right conversations up front about what will these interventions do and when will they perhaps not be helpful, which kind of takes us to our conversation about advanced care planning. And at the heart of it is really uncertainty. I tell families, and I may have shared this before in a weird way, I feel like our team specializes in uncertainty. It's obviously completely made up. It's not a specialty, but for the vast majority of the kids we follow, nobody really knows their prognosis. We think we do, right? We tell families things like, oh, they'll live till they're 24 months. That's a literal situation right now. And the family fully expected they live to 24 months. The problem is their condition is, there's maybe a few hundred kids that have it. So the data is obviously pretty terrible. And then how does that change if you do a trait? Does that push it out another year? We don't actually know. And we have to admit that, which is we do with families all the time. And we're not sure. Your child's condition will tell us what they need, and we'll talk about these different interventions along the way. But we like to think we know, I think, more than we do when it comes to these rare conditions in pediatrics. So just a word in the last couple of minutes about how do we do this advanced care planning then in pediatrics when we can't necessarily know what the future looks like. This road is incredibly windy. We often start with simple questions, which I feel like sometimes these are oversimplified, but we just sometimes don't ask them, at least not often enough, to a family. What has the doctor told you about your child's prognosis? And we hear all kinds of things about some pretty, I think, concrete numbers that I always usually disagree with. Because, for example, a child with Zellweger syndrome, a rare brain disorder that causes terrible seizures. We met a family last fall, asked them this question. What did you say? Well, she was diagnosed at 8 months of age, and the neurologist said she probably won't live another year. I appreciate the honesty in that conversation. The challenge was she was in the hospital at age of 17 years. So she still has Zellweger, still has all the bad things. She got a trait when she was 4. But here we are with the same disorder and slow decline over the years, and we're off by about 16 years. So that can create a lot of mistrust for families. And I take that uncertainty head on, and I admit what we don't know. Like, I know that's what some papers may say, the books may say, but your child is the more important part of this. They'll tell us kind of what this looks like and when things become obvious that they're changing. And then the obvious questions, and we do ask this: would you pursue aggressive interventions? If your child needs help breathing, if they need a tube to breathe, or they need their heart restarted, would you want those interventions? And I always ask residents who are with us these questions, and I probably confuse them, but I get 2 answers. Majority of the time I get yes, we would, right? Even in the most horrible situation, many times families their gut reaction would be, yes, we want those things. It depends how you ask the question, which I could talk for hours about, right? Do you want your child's heart restarted? That sounds great. Do you want us to help their breathing if they can't do it on their own? That sounds awesome as well. But the problem is, are those interventions actually going to help? And what does that look like in the long run? So if you ask the question, it sounds like, oh, that's a good thing. Yes, I'd want you to help my child. So we have to be careful how we ask them. But the other answer we get many times in these more chronic situations are, it depends. And this is where, again, I'm a big fan of humility in general, and certainly in medicine. We have to admit what we don't know. So the depends usually comes down to, is it reversible or not, right? My child has a pneumonia. Yes, they've had this chronic condition, but can we treat this pneumonia and get out the other side without maybe more intervention? And the problem is, we're not smart enough to know that. Now, we may know from the past few months how stuff's progressing and what does it look like. And I'm worried they won't come off the ventilator and things, but that's the answer we get from a bunch of families. And I have to tell them, well, we simply don't know, right? And even the smart ICU docs can't necessarily tell you, is this reversible given everything else your child has? We may not know. So the most important question I feel after that is, what if you started something? What if your child was intubated? Would you be able to stop it? Could you imagine a scenario where they're stuck on a ventilator? Now they're not, they won't survive without that ventilator, and you would be in a spot where you would remove that technology and allow them to pass. To me, that's probably the most important question that we can ask families. And I've seen both sides of it. Families will say, yes, we know that we may have to do that. And as awful as it would be, we know that we may come to that. I've had other families who will say, no, we're not going to cross that line because it would be too hard for us emotionally to stop. So we're not even going to do it. So to me, that's the most important question. And then kind of everything in between, right? Because families will change their mind. I've had families who tell me that at the diagnosis of their rare, terrible thing, we don't want to prolong our child's life in any way artificially. And 6 years later, that child had a trach, vent, G-tube, suprapubic catheter, and their home was like an ICU, and that's okay too. So there's lots of conversation along the way, but these are the kind of questions that I think are important for us to ask. And as I mentioned, starting planting those seeds way early on is something I'm very passionate about, because there'll come a time when we may need, I should probably change that to will need, to talk about whether this intervention is helping. And I firmly believe that, whether it's a ventilator, whether it's artificial feeds, for these kids that have chronic, lifelong, I'd argue degenerative conditions, because even chronic lung disease eventually will catch up to you and raise more questions. I think these are we ask this and insert this early on so a family's not slapped in the face and say, I had no idea that a trach was even on the horizon. Well, I think the whole medical team did based on the last 6 months. But again, we need to start having those conversations earlier so that families aren't surprised. So I always say this, that advanced care planning in PEDS is not really about the answer. This is not about a signed document in PEDS that says, this is what we're going to do, forever hold your peace. That happens occasionally. When it does, those are hospice patients, right? And even there, it's kind of gets confusing at times, as we'll talk about, I think, in January about concurrent care. It's more about the journey, though, about what might you think about doing? Where would that line be? Is it going to move later? It's more about the journey than about the actual decision. And I added this slide this year because really what this comes down to, and there's lots of literature about what does it mean to be a good parent for a family in the ICU or in oncology or these different serious illnesses. And what it comes down to is, what do you feel you need to do for your child to feel like a good parent? Is it going to Monterrey, Mexico to try to get treatment for DIPG because you're willing to turn over every stone? I'm going to support that. If I think it's hurting your child, I'm going to say, I'm a little, are we at a different spot? But I'm not the parent, right? And talking about regrets, would you regret doing too much to your child and having them suffer needlessly? Or would you regret not trying that other treatment, right? Being very honest about that with the family and asking them to weigh those things in their mind. I often use the language around loving decisions. I think we have a tendency, especially in PEDS, to just do more, right? We have technology, we have machines. You care about your child, you should do this next step. And I cringe at that, because I've told many, many families, obviously usually after I know them for a while, that sometimes the hardest, most heart-wrenching thing you can think about doing, like perhaps stopping, is also the most loving. And that, I think, is a really odd place for a family to be. And we have to support them in that, if not maybe encourage it at some point of, hey, I know this is hard. I know you've thought about it. We've talked about it. I wonder if we're at that point where this machine is not helping. I just asked a family who's in the hospital right now. They know their child won't survive. He has a rare neurodegenerative thing. And I asked that question. I said, at some point, there will come a time when this machine, he's about to go home on a ventilator, that this machine will not be helpful. She literally covered his ears and said, I don't want him to hear this, but these machines have never been helpful. They've never given him the quality of life that I've wanted. That is a beautiful and heart-wrenching statement and deserves a lot more conversation about, okay, then how do we help you get to a spot where, I don't know that okay is the right word. We don't have good words for that. It's not okay. You don't feel okay about stopping. You're not okay with this plan, but you know that it's what you need to do. Obviously, lots of hopes for miracles sometimes. And I think we talk about that somewhere in the lecture series. And Barb, I know, has taught me a lot about that as well, about how do you define a miracle and what does it look like? Is that miracle perhaps a peaceful death as opposed to a cure? Is that miracle not here, but on the other side, that I've had families share with me in beautiful ways? And a lot of this is about fear of giving up. Families don't want to give up too soon. Some of that we promote that in our medical language sometimes, of just keep fighting, right? We'll do it. And there's a big fear on the medical team side of giving up as well. I think that's a huge problem in pediatrics. Is PEDS people are trained to not give up. We fight for children, and we have to. A lot of our work in palliative care is actually with the team to say it is okay. The best thing you can do for this family is maybe not offer that next chemo, but to tell them we are truly at the end. And they need that honesty. So again, there's some more academic ways to look at this. I found this from a couple of years ago. It's all the same stuff we talked about. Patient and family in the middle, quality of life, beliefs, values, hopes, and goals. This is how we surround these families, and year after year talk about how do these things change? How do we help you weigh these different interventions? I won't perseverate on that. There are some other resources that we use. Many of you are familiar with the 5 wishes, which comes out of, I think, Aging with Dignity place. We use that sometimes with our older patients. Voicing My Choices is the teenage version of that. More language geared towards teens and adolescents. And My Wishes is a similar version, but actually uses pictures to draw who do you want to be with you, what are your fears, and that type of thing. So there are some other tools out there we use in these conversations. So in summary, and I know I'm right on time, and at least I'm glad I didn't go over as usual, it's about communication. That's not a surprise to anybody on this call, I realize. Honest communication with family and between medical teams. As I mentioned, a lot of our work is trying to get teams to talk to each other about perhaps where we are and what makes sense and what doesn't. Assessing their goals, fears, concerns, and reassessing later. And I think sometimes we don't do that, as I mentioned. We do it up front and say, what do you want to do? Oh, you want to prolong your child's life, great, this is the plan. And we don't come back and reassess. Did this actually help? How do you feel about it 6 months, a year, 2 years later? And supporting families no matter where they are. I have strong opinions and feelings about some of the things we do, but I have to put those aside, at least in how our system works, because families can choose. Now, we could debate for a long time about should they be able to choose and everything else. I love having those conversations, but the fact is families get to choose, and then we have to help support them as the next steps happen and try to take that burden off their shoulders. Again, the language we use is hard. We tell families in the ICU sometimes, well, you can choose, literally pointing, you can choose to take them off the vent if you want. That's a horrible statement, right? How about we can talk about the next steps and removing technology and whatnot. I put a question mark next to ethics consults because I don't always believe that they're super helpful. No offense to my ethics colleagues, because sometimes there's not a pure ethics question. Because I know the answer from ethics might be, you could consider limiting the interventions offered to this family, but logistically and legally, how do you actually do it? So I love the conversations, and I think ethics is often more helpful around the moral distress that we sort of create in these scenarios for our staff, in particular, bedside nurses who care for these kids day after day and struggle with kind of what the goals are. And as I mentioned, lots of education about other providers. So I apologize, I ran over. I always include a picture of the kids, which I personally struggling in full transparency with the fact that that young one just turned 10. And when I started doing these lectures, I think he was 2. So that's my own personal struggle lately, but they keep getting bigger. So happy to take questions. So I'm sorry I ran long, but I think I've done worse in the past. So appreciate your attention. And Matt, Dr. Meisner, I wonder if you have any comments from your ethics and pediatric experience.
Yeah, I put a few things in the chat for you. First of all, I wanted to say, I think you were giving yourself too little credit. That was an excellent presentation, by the way. It really touched it. And for me, I guess some of the things that I would like to mention is I totally agree with what you're saying. I think it's very hard for me to say that, you know, for the case of artificial nutrition and hydration, right? Or artificial ventilation, you know, for an adult, it just seems like, yeah, of course, they can make this decision. You can do it. You can pull it off. No big deal. But with a kid, you got to kind of go full court press. And sometimes it feels real sticky, you know. The other thing is, I think that we have to consider is a lot of this, or at least for me, you know, I bring on kind of a faith position too, right? We all have that. And I think that's a kind of maybe a biased position that I come from. But as a practicing Catholic, I've always had an issue with the artificial nutrition and hydration issue. The Catholic Church, not to preach Catholicism, but it's really big. You know, they basically view these decisions through the eyes of ordinary versus extraordinary care, right? And the ordinary care is what you would normally do for the average person. So putting somebody on a, let's go start with extraordinary. So taking a child and saying that he or she needs to be on a ventilator is less problematic in the sense that you didn't come in with it, so you don't necessarily have to exit with it. So I can start it or not start it, or if I start it, I can take you off of it basically anytime I want. Now, that doesn't mean it's that easy kind of emotionally, but as far as the permission, you're granted. But with artificial nutrition and hydration, that's considered ordinary care. But my question has always been, well, did I come in with a tube, right? I mean, it'll never get answered, you know, and most Catholics, I think, would sit here and say, no, I kind of view it the same, but I don't get the same response when you're talking to the priests, the bishops, because it really came down to, and not to beat them up, because I really think these great things, but John Paul II back in 2006-07 was the one that kind of put it out there for the church that said, you know, this is ordinary care. There's really little to no like space to say that you are not starving if you don't do this, right? The interesting thing to notice, he was actually dying of terminal Parkinson's disease, and a lot of people, there's kind of this thought out there that he was actually G-tubed at the time he made that statement, but that's beside the point. So I'm kind of getting off topic, and I'm not here to preach Catholicism, but that's kind of my central point. I personally have confusion when I'm looking at these issues that again, what I think you had touched upon, that we almost give free right to an adult decision, but we can't see that you're looking at a terminal case with a child, right? But all hands on deck, right? And then the other issue is, how can I look at a vent and say that that's not really the same as a G tube? And then the last thing I'll throw out, because I'm kind of taking over, I'm not trying to, but you know, the other thing to mention is there's this thing that we call the slippery slope, right? And that is a realistic thing when you look at to a certain degree. I mean, you can't just jump and say, well, if we allow this to happen, you know, for instance, the thought of pediatric euthanasia, and I kind of put if you look at my comments, you know, in Netherlands, they have now basically kind of followed what was first stated in Belgium, that they have now giving children under the age of 12, in some case, in incurable conditions, the right to receive euthanasia. And so the question I always have is, okay, so where is the definitive stop point, right? In a case like that, was it 16, 18 okay, but now it's 12, and now it's 12 and below. And so I don't know what you think about that, Brad, but so it's not clear cut that way either. I'm like, I believe that you should be able to stop that too, but is there a limit? And that's something that none of us, I really think, can answer. Can we? I mean, I don't.
No, I would agree with that. I'm glad you brought it up. I think that is, you're pointing out the innate challenge in this is, I don't think there is one single answer. I do think it goes back to the individual family. And I appreciate what you said about the Catholic approach. I think we have families that struggle with that as well, yet they also feel their child is just miserable and suffering and they're torturing them. I think your comment about, and I say this all the time, that the art of, I find it interesting, and not that I'm not trying to challenge you on that. I just find it interesting that the artificiality, is that a word, of a ventilator versus an artificial tube in your stomach to feed you, right? I often land on those are both very artificial. And it's always been interesting to me, and you would be better to answer this, but that idea that the normal, that it's the ordinary, artificial feeds are ordinary, but at some point they weren't, right? At some point we did not have tubes that we could insert and do this on a routine basis at home. So I also find it interesting how that directive ethically changed once you have technology. So I think the other slippery slope is always a worry of mine on the other side. And I absolutely agree with you about the euthanasia. And I think we could talk about this obviously forever. I feel like we'll have some good conversations when you're with us, by the way. I worry about the slippery slope the other way. We talk about needing a lot. That language comes up a ton of the child needs a trach. And I always use quotes. It's my by default when I say need, because need only depends on what your goals are. And where's that slope of, well, we all need, I hyperbolize often, we all need a trach, a vent, a G-tube, insulin, dialysis, and whatever fixes the liver. If we could fix that, I feel like then we could just do it all. Never mind the brain part. But I feel like that's the slippery slope on the other side that we could be in. And we paint that picture to families of, well, this is what your child needs, because of course you don't want them to die. And that, I think, is not the right assumption sometimes. So I realize we could keep talking for a long time, and I don't want to take Mara Sue's time with her case as well. But I appreciate what you put in the chat as well. And, you know, I think we also have a whole conversation about the Amish and how to handle that. And when you're with us, we'll talk about some interesting situations we've had as well. How do you respect their culture and what their wishes are and how they approach life? But then in some ways, not so much. So